Absolutely. So thank you all very much for joining us today. It's an absolute pleasure to speak to you guys about a topic that's near and dear to my heart. So we heard about all the initiatives that we're actively working on, and everybody's tackling the issue. Like, we're all, like, our heart's in the right place. Everybody's tackling these issues in the same, like, in different ways, but the problems are still the same. So one of the problems I've been trying to focus on has been like trying to identify the barriers and eliminating these barriers one step at a time. So one of the things that we've been trying to work on is we're in more than 100 countries. And when we say that, the problem is very different in every country. And one of the things we've been focusing on is trying to identify what are the social and cultural barriers to advancing thrombectomy care, stroke care, and advancing thrombectomy care. So again, I'm not going to belabor this point, but low middle income countries are geographically and socioeconomically diverse, with differences in adherence to stroke-related care and outcomes. And they're well-recognized risk factors such as metabolic syndromes, high blood pressure, diabetes, that have steadily risen over the past decade. By 2030, the World Health Organization predicts doubling of stroke deaths, rendering an investigation into regional attitudes regarding stroke prevention and treatment highly necessary. Also, like an investigation into like the region highlights well-resourced countries' approaches to and beliefs regarding stroke care, as well as poor, deeply traditional, and conflict-stricken ones. So there are many gaps in lower middle income countries that can be attributed to low resource availability. And it's so easy to say and blame, like not blame, but basically like just say, oh, it's because they don't have money. It's actually beyond that. There's a problem. It's a bigger problem than just resources. You can you can build an Andrew suite for a couple $1 million. You can invest in EMS, but ultimately just bringing everything together can be pretty complicated. So resource underutilization can be attributed to a host of factors. And we were just speaking just before this meeting, how there are countries that actually have a biplane and have an EMS system, but when it comes to essentially doing the actual procedures, that is essentially where the gap is. Or they may not necessarily have an interventionalist, even though they have highly trained physicians who can do renal transplant and they can do corneal transplants and can do very complex surgeries. But when it comes to not to belittle and simplify mechanical thrombectomy, but it's much less, probably much less involved than other potentially more complex surgeries. So in order to effectively address these social and cultural barriers to receive care, these must be investigated in the context of the cultures in which they arise. Beliefs about illness can impact outcomes and prevention uptake. So please let me know when I have 2 more minutes just so I can go through this. So one of the chief barriers to obtaining emergency stroke care in the region is limited education regarding emergent nature of stroke and stroke etiology in general. Downstream effects of this lack of awareness results in ill-prepared health systems with lower use of effective therapy. So one of the topics that, and when we started working on this, it was actually a little bit hard to give a name to these concepts. They do not exist. I had to dig into like basic public health interventions and look at like, why is it that coronary interventions do not exist in some parts of the world? And ultimately, we came up with like different reasons, and we actually coined some of these terms. So the first term is health fatalism. The second one is religious health fatalism, lack of knowledge, healthcare skepticism, and alternative medicine. So with regards to health fatalism, this is a belief that severe diseases are by default uncurable and untreatable, and and this concept prevents a broad variety of patients from seeking help when treatment options can potentially be available. Furthermore, other reports demonstrated that like this can negatively influence individuals' health behavior and thereby impeding them from becoming active participants in their healthcare. Such beliefs affect not only stroke care, but other medical conditions. Additionally, it significantly impacts recovery and the risk of recurrence or mortality. Spiritual and religious fatalism. So these are some parts of the world where there's a belief that if I am sick, it is because this is, whether it's God or any higher power, that is the will of the higher powers. And who am I to essentially challenge that? If I am destined to have a stroke, then so be it. Let me have a stroke. And this is prevalent in highly religious societies where fatalism can actually be intertwined with fate, thus leading individuals to relinquish efforts and seek help as a result of external loss of control. Nothing can happen outside of God's will and God's control. Hence, the patients will ignore the advice of their medical practitioners and providers. Patients may then develop a defeatist view, attributing their illness to a curse or a punishment from the higher power, and lead them not to seek care. Lack of knowledge, and I think that is probably one of the biggest problems that we're going to face. Globally, patients are not trained to recognize the symptoms of a stroke. And this can definitely delay treatment. I cannot tell you how many times I've had somebody reach out and say, yeah, they had we're not sure. We just heard that they had a stroke. I'm like, when did the symptoms start? They say, oh, it started probably 2 days ago. They were weak in one arm and a little bit weak in their leg. They were dragging their feet and they thought they could just sleep it off. Or they figured if they can go to sleep and wake up the next. There's lack of knowledge on what exactly the symptoms of stroke are. As easy as it is for us to say, yes, be fast. Sure, even in the United States, a lot of people do not know the symptoms of a stroke. Rural individuals, and this is probably more common in rural than urban areas, and rural individuals in many countries are usually tolerant of painful conditions. Thus, they may refrain from seeking care and miss the therapeutic window entirely. Healthcare skepticism. I think this is a serious problem. So there's lack of interpersonal trust in the patient-physician relationship. And this encompassed within this belief is within that entity is that the object of mistrust is actually acting against the individual's well-being or best interest. Historical context of past clinical experiences and past clinical research, past medical treatments in which they or others may have experienced, and then they feel that there was a negative association with this, and they say, well, my neighbor went to a doctor and they died. I'm like, yeah, but they died because they had 5 organs were failing. You're not the same person, but they do not believe this. A simple example that I had to dig up for where does this originate? And I actually found a good example in the United States. 2 minutes. All right, good. Found an example in the United States of the Tuskegee syphilis study, which consisted of enrolling marginalized Black men subjected to syphilis, who were then monitored into the progression of the disease without being treated. This is even with the creation of penicillin. This contributed to certain social, ethnic, and minority groups to mistrust the medical community. And quite honestly, I would mistrust the medical community too if I felt like I was being being treated in such a way, of course. And alternative medicine, lots of alternative medicine exists all over the world, and is essentially any said diverse behavior which uses several method products that are not usually used in traditional medicine and not supported by evidence-based medicine. And these include using, again, not to belittle these beliefs. I believe that these are core beliefs of individuals, but it's important to try to highlight them. In China, there is a huge field of alternative medicine, and in some cases it may work. I will be the first to acknowledge that I don't know enough about this, so I would never belittle these interventions. However, we know that thrombectomy works. We know that TPA works, and it's important that we offer these interventions to people. So despite the success of the Resilient trial, and again, kudos to Sheila Martin and Raul Noguera, and looking at the Resilient trial and the Resilient trial that was presented, the new trial that was presented recently in Latin America, these great strides taken are still large. There's still large cultural barriers in awareness in the clinical manifestation of stroke, and the need for rapid treatment amongst, for example, the Brazilian population. The popular Portuguese expression for stroke is derrame. Correct me if I'm wrong, which literally translates to a leak. Unfortunately, this terminology may obscure the etiology of a stroke and lead to confusion of stroke for myocardial infarction for anything else. Hence, an increase in the availability of endovascular thrombectomy must be simultaneously accompanied by a cultural shift in the populations to improve end utilization rate. So I think I have like 10 more slides. So in the interest of time, I'm not going to go through these 10 slides just because I need to allow my partners and my colleagues to speak. But what I'd like to say is we're working on, similar to the MT glass, we're working on another paper called MT barriers. We're trying to identify exactly what the problems are, so that when we approach like a country and try to initiate this, just like with Resilient, for example, you're concomitantly attacking or tackling the problems that are preventing the patients from coming to you. You can have the best EMS system, you can have the best interventionalist, you can, the physicians can know about this, but if they come and it's very late, it's going to be like, they will not be able to receive these interventions. So hopefully to the people in the audience and the people watching online, I will, once we have a protocol in place, a methodology in place, hopefully in collaboration with Kez Asif, Santiago Ortega, and under the leadership of Dilip Yavagal, we'll be able to invite you all to be part of the MT barrier study. Finally, I'd like to say I'm absolutely honored to take over machine thrombectomy from a global chair perspective. I always tell this to Dilip. I think it's cute that he thinks he's stepping down because he's not going anywhere. He will still be here. We're not letting him go anywhere, but it's absolutely an honor to serve in that role. Thank you so much.